Αγαπητοί συνάδελφοι, καλημέρα και από εμένα. Έχω τη χαρά να συμπροεδρεύω μαζί με την κυρία Μας ακούτε? Καλημέρα σε όλους. Είμαι η Αθηνά Ιβούρτση και έχω τη χαρά να συμπροεδρεύω μαζί με την Άννα Βρετού. Είναι συνάδελφος και εργάζεται στο Μετροπόλιταν. Μετά την εξαίρετη ομιλία του κύριου Ηρακλήδη, έχουμε τη χαρά και την τιμή να σας παρουσιάσουμε μια εξαιρετική συνάδελφο, η οποία είναι γνωστή στο αντικείμενό της. Είναι ακτινολόγος, δεν ξέρω αν μας ακούει. So, good morning. Good morning, Dr. Takwal. Yes.
Dear colleagues, the next speaker is Dr. Amruta Talwalkar. She's breast. So the next speaker is Dr. Amruta Talwalkar. She's director of the breast screening in South Lancashire. She's responsible for the leadership, performance, management, and coordination of this program. Dr. Amruta, can you hear us?
Yeah, I can hear you.
Okay. We're waiting for your presentation.
Okay. I'm going to share it now.
So the topic is on breast radiology for surgical planning and decision-making, present and future. Looking forward to hearing you. Thank you.
Can you see the presentation? Yeah.
Yes.
Okay. So thank you for the kind invitation today to speak about this interesting topic. I have no declarations for this talk today. I'm going to talk about why imaging is just not diagnosis on its own. It's a blueprint for surgery, defining where and how to cut and how much to remove. And it is about a pragmatic framework for selecting patients and balancing benefits against real-world constraints. So imaging provides preoperative insights. It enables accurate surgical planning, reducing unnecessary reoperations, and we therefore ensure that the correct procedures are performed at the first attempt. So I'm going to talk about how much imaging. I'm sorry, this has moved ahead. So I'm going to talk about why breast imaging is so critical to surgical planning. First of all, it defines tumor size and extent, because how else can we plan accurately? It detects multifocal and multicentric disease, and by mapping the tumor to breast ratio, it addresses key questions like breast conserving surgery or mastectomy. After neoadjuvant chemotherapy, how do we know that the tumors truly respond? We turn to radiology and imaging. For the axilla, which approach is safest, sentinel node biopsy or targeted axillary node dissection? And finally, it helps balance oncologic safety with aesthetic goals like oncoplastic planning. So let's talk about imaging choices first. Mammography and ultrasound, why do we still call them first line? Because they're complementary, they're accessible, and they form the backbone of diagnosis. But what about dense breasts or invasive lobular carcinomas? Can we rely on mammography alone? This is where MRI demonstrates highest sensitivity. Now, what if MRI isn't available or feasible? There are new emerging techniques like contrast-enhanced mammography, which steps in as a pragmatic alternative. It's fast, it's cost-effective, and it's patient-friendly. And looking ahead, how do we predict nodal status or response to neoadjuvant therapy before the scalpel? Radiomics and AI are emerging tools. So the question is, are we ready to integrate these tools for smarter, more personalized surgery? So we know the importance of conventional mammography and ultrasounds for preoperative diagnosis of breast cancer, but breast MRI is a valuable adjunct in the diagnostic workup of breast cancer. Its use varies across international guidelines, and this slide demonstrates the sorry, this slide demonstrates the recommendations from different organizations throughout the world. And the recommendations differ based on clinical scenarios, and there are such as discrepancies in tumor size estimation, breast density, invasive lobular carcinomas, and high-risk patient profiles. As you can see, while some organizations advocate routine or optional MRI in specific contexts, others reserves its use for cases where conventional imaging is insufficient. So understanding these variations is essential for evidence-based practice. The common indications in these groups are dense breasts, precluding mammographic assessment, invasive lobular carcinoma with breast conserving surgery, and discrepancy between the extent of disease on clinical exam and mammography or ultrasound assessment. So why preoperative MRI matters? There's been a huge paradigm shift in the landscape of multifocal and multicentric breast cancer, and it has been revolutionized by accumulating evidence which demonstrates that breast-conserving therapy can achieve equivalent oncologic outcomes when all tumor foci can be completely excised. So preoperative MRI can detect additional disease and then change the extent of them. As we see in this 60-year-old patient who presented to our breast screening unit, there is a small focus of asymmetry detected in the right outer breast. This was biopsied and found to be an invasive ductal carcinoma, but there was a concern about the degree of glandular tissue surrounding this density, and therefore she underwent an MR. Now, this is a sagittal reconstruction of an MR image which showed the original cancer and further foci of enhancement posteriorly and inferiorly. And then this is a slightly more advanced 3D maximum intensity projection of the same image, which shows the tumor as in a slightly better format, and it was shown to be a 65 millimeter multifocal tumor. This therefore changed her surgical options, and she went for a wider excision. So this slide is demonstrating the MIPA study, which was a global prospective study across 27 centers, which compared mastectomy and reoperation rates with and without preoperative MRI. So the patients were, there were roughly 2,700 patients who did not have MRI and 2,400 who had MRI. And patients who were sent to MRI were either in the screening setting or in the diagnostic setting with younger, more perimenopausal status, patients who had denser breasts, and a higher proportion of multifocal and multicentric cancers diagnosed before MRI on conventional imaging. So in many cases, MRI, when done for diagnostic purposes, was as a confirmation tool for mastectomy already planned before MRI. And this study found a slightly higher rate of mastectomy in the MRI group. It was accounted for various factors like patient choice, additional conversion from conservative surgery to mastectomy, and some other reasons. The reoperation rate for positive margins was significantly lower in the diagnostic MRI group, 8.5%, to the group with no MRI, which was 11.7%. This is just an example of a screening MRI that detected these two small foci of cancer. This is a previous mammogram. In the left upper breast, two small grade 1 cancers were detected in a high-risk screening patient. She subsequently had an MRI because of her risk factors, and this was a biopsy from the original cancer. We found a third focus, which was not amenable for ultrasound or mammographic examination. She therefore had an MR biopsy of this, which found further cancers, again changing her surgical landscape. So what are the limitations of MRI? You have to balance the fact that there is a slightly higher mastectomy rate in population studies. And remember, there's no clear survival benefit for unselected patients. So the selection criteria in a multidisciplinary approach are important. And then a final caveat in our preoperative utilization of MR. This is an example of a 54-year-old patient who presented with a palpable lump in the left breast. I don't know if this is projecting properly, but you can see there was calcification in the breast extending from the inner posterior aspect all the way up to the anterior aspect, measuring 54 millimeters. And corresponding to this area, there was multifocal tumor on sonography, which was biopsied. She subsequently underwent an MR scan, which demonstrate this is a 3D MIP image, again demonstrating that this was an extensive more than 50 millimeter area of cancer in the inner half of the breast. This lateral breast nodule was biopsied and found to be a fibroadenoma. Following neoadjuvant chemotherapy, the cancer showed almost complete radiological response. The fibroadenoma stayed the same. She had mastectomy by patient choice, but then it was found that there was extensive DCIS present in that area of calcification. So DCIS in routine MRI MRI does not improve outcomes for DCIS and should be used with caution. So who benefits most from a pre-op MRI? Patients with invasive lobular carcinoma, dense breast and younger patients. When this discordance of imaging or suspected multifocality and assessment after neoadjuvant chemotherapy for disease mapping. And then we come to the next way of assessing a preoperative breast, that is contrast enhanced mammography. This is a functional imaging study performed by administrating intravenous contrast. And the use of CEM has increased in part due to its accessibility and the ease of use. The indications for CEM at present are variable and include evaluation of the symptomatic breast, pre-surgical staging, assessment of response to neoadjuvant therapy, and in the presence of contraindications for breast MRI. It has also been evaluated in the recent BRAID study in the UK, which was a randomized controlled large-scale trial of more than 9,000 women. They assessed the value of supplementary MR, including CEM and abbreviated breast MRI to diagnose breast cancer. Now, the interim results have been published in the Lancet, and they demonstrate that the supplemental contrast imaging facilitates earlier detection of cancer with no differences between breast MRI and CEM. But there is a slight lack of benefit for additional cancer detection. Now, there is also a multi-center US study ongoing called the CMIS study comparing DBT and CEM. These are just some real life examples of the use of CM. This is an 80-year-old patient who had presented with a mammographically visible multifocal tumor, which has been biopsied on your extreme left image with some density posterior to it. She then had contrast enhanced mammography, which demonstrate enhancement in that posterior area, which was further biopsied and found to have a further invasive ductal carcinoma. And then on the post-therapeutic mammogram, she had further contrast enhanced mammography, which showed good response to treatment in the primary tumor, and the posterior enhancements almost completely disappeared. This is another problem-solving example for CEM, a 77-year-old patient with a history of right breast cancer and suspected recurrence on conventional mammography, showing a stromal distortion here posterior to the nipple on the right. She underwent contrast-enhanced mammography, demonstrating no further enhancement and therefore saving further invasive investigations for the patient. So from the breast, we now look at axilla and the role of imaging. So axillary node status is critical for prognosis and treatment planning in breast cancer. But recent changes to guidelines in neoclinical trials advise avoiding axillary node surgery in early stage cases with limited nodal involvement. But for more aggressive disease, treatment and surgery is advised. Now, these are images of a band or enlarged lymph node with abnormal vascularity, but very often we don't see this sort of clear changes in nodes. And in those cases, MRI and ultrasound have a very high false negative rate. So we then resort to sentinel node biopsy. And this is a standard but invasive and costly technique and carries complications and risks. So a newer, more advanced technique that has been studied recently is radiomics. It offers promising solutions by extracting features from the primary tumor. It still does not replace clinical judgment or pathology, but there are multiple studies showing promise with a move towards radiomics in the future. So just a little diagrammatic representation of how radiomics works. So the first step involves acquisition of images. So this is an MR acquisition showing the primary tumor and a very small axillary node. The area of interest is selected and plotted, and then it is changed into a 3D rendered map. And then software is used to extract qualitative and quantitative features, which with other data like clinical information, genomic profiles, produce a score. And in most cases, they call it a RAD score. Now, this is a trial with the retrospective analysis of 1,200 patients with early stage breast cancer across 4 centers. They extracted radiomic features such as shape, texture, and other features to produce what they called a RAD score. And it was found that there was a strong correlation between the RAD score and prognosis. So just for example, this top line here shows a 37-year-old patient with a clinical T2 stage disease, which you can see on the MR scan. This MR was then underwent radiomic analysis, and they gave it a RAD score of 0.137, which was predicted as a low score and low for axillary lymph node burden. And on the outcomes, they found that there was no axillary lymph nodes, metastatic nodes with a low burden. And in the bottom, you can see a 46-year-old with T2 stage disease. There were no suspicious metastatic lymph nodes on the original MRI, but the RAD score for that tumor was 0.704, which is a high predicted burden. And on eventual surgery, there were more than 3 metastatic axillary lymph nodes. So there is these studies are showing promise towards actually using non-invasive techniques to predict axillary node metastases. So a little bit about perioperative imaging. We are still using in large areas conventional technologies like lesion localization with wires, and then most centers in the UK now use radio tracer seeds, which are non-wire localizational techniques and magnetic localization techniques. And for sentinel node biopsy, we are still using in parts isotope-driven localization techniques. And again, all of that is about to change with the advent of radiomics. And being a breast radiologist, I cannot escape this surgical de-escalation and minimally invasive breast procedures, which are also on the rise. And one of the most talked about technique at the moment is cryoablation of tumors, and other modalities like radiofrequency ablation, microwave ablation, high intensity ultrasound focused laser therapy, and vacuum assisted excision. We are in the UK as a center in South Lancashire, one of the first centers to enroll into the vacuum assisted excision study, which has been performed, called SMALL. It is a randomized controlled prospective trial which compares open surgery against minimally invasive vacuum assisted surgery for early breast cancer. And the case selection is about to close in this summer. So what other techniques might be help in the perioperative scenario? There are emerging multimodality segmentation techniques to look at volumetric breast assays, and for breast reconstruction, CTA mapping or MRA mapping of the perforators for the DF flap reconstructions. We then move on to neoadjuvant therapy and imaging roles. We all know that it's important to map tumors in the baseline scenario with most of the times we do this mapping with MR, and then there is use of clip placements and targeting. There's also MRI assessment of response, and imaging also that defines the extent of disease for post-surgery with possible feasibility of breast conserving surgery. So this is, again, a recent paper which went through a systematic review of 147 clinical trials, which looked at imaging, which was utilized in response assessment for during or after neoadjuvant therapy. And there was significant variability in the modalities used, the timing that the imaging was performed, and the criteria applied for the response assessment. So this highlights a lack of standardized protocols for response monitoring and subsequent actions based on assessment for therapy. And clinical trials around this are proportionally low. So to make full use of imaging in neoadjuvant a therapy setting, several steps are necessary. First, the imaging response assessment needs to be performed in a standardized manner. The treatment algorithms need to be established and to guide the potential response modifications based on imaging. So what are the emerging tools that might help in prognostication before and after surgery? One is what we've already talked about, the use of radiomics in sentinel node and axillary metastases. There is also an emerging role of predicting the Ki-67 as a key marker for therapy and response, and radiomics using contrast enhanced MRI have shown associations between imaging features and Ki-67 expression, and further uses of ultrasound radiomics for axillary node detection. Now, FDG PET is the current use of FDG PET is mainly in evaluation of distant metastases, but it is also being increasingly used for surgical initial staging and post-therapeutic restaging, and to guide radiotherapy and surgical planning. In the diagnosis of breast carcinoma, most studies report a sensitivity of 50% and a specificity of 70%, and they are closely related to the histopathological subtype of the tumor. Now, this is an example of 42-year-old woman with newly diagnosed triple negative breast cancer in the right breast, and the upper row shows a whole body PET, axial and coronal slices before neoadjuvant chemotherapy, showing highly increased tracer uptake with diffuse alteration in the right breast, which is here. And in the lower row from the left to right are again subsequent images following treatment, and it depicts a reduction in the tracer uptake within the primary tumor, but an increased sort of pathological axillary lymph nodes, and then the patient was classified as a non-responder. So this is an importance of FDG PET. There's also an emerging evidence for radiomics showing good potential for predicting neoadjuvant response and molecular profile in breast cancer. So to bring it all together, it is important that we use a systematic multidisciplinary approach to look at all the imaging modalities perioperatively and postoperatively. And in Italy, a multidisciplinary model for management of breast cancer called ROME, which is radiological and oncoplastic multidisciplinary evaluation, has been developed. This is very similar to the multidisciplinary team meetings that happen all over the United Kingdom. And these models integrate the expertise of multiple specialties to present a patient-centered approach with early oncoplastic input to avoid late complications. So for a pragmatic selection framework for each patient, we start with mammography and ultrasound for most patients. We add MRI for invasive lobular cancers and dense breasts with discordance, suspected multifocality, and neoadjuvant chemotherapy. We consider CEM where MRI is unavailable, and we avoid routine MRI in uncomplicated or concordant DCIS cases. What are the research gaps in current imaging techniques? There needs to be a sharper grouping for MRI CEM benefit, but given that CEM is an emerging modality, this will come. We also need some prospective AI validation to look at radiomics and its uses in prognostication and long-term quality of life outcome studies towards oncologic and oncoplastic procedures using imaging-driven technologies. So some take-home messages: use MRI selectively, not routine for all. CM is a practical alternative when MRI is limited, and MDT and oncoplastic input are critical to avoid overtreatment, and you leverage imaging to get the right operation first time. Thank you.
We thank you, Dr. Talwalkar, very much for your great overview on the current role and the future of breast imaging for surgical planning. I know their questions are not allowed. Just a very quick question on how is imaging performed in your facility? We know that when we have very high workflow, there is sometimes problem with timing and scheduling. So how much time does it take initially from having a BioRADS 405 lesion found with mammography or breast ultrasound until the patient goes to biopsy and has the MRI or CM performed? Thank you.
So we have two different work streams. One is a screening pathway where from presentation or sort of diagnosis at screening, the initial diagnosis has to be given within 2 weeks to the patient. That is an NHS breast screening program target. And there is a further target for the first treatment to be administered in the next 2 weeks cycle. So the screening pathway is very streamlined, and usually there are no delays in that. We do find that there are sometimes delays in symptomatic presentation. It is a guideline within the UK that all patients are seen in a one-stop service, which means that they have a triple assessment with their initial diagnostics and biopsies done within one assessment, and the subsequent diagnosis or histology from that biopsy happens within 2 weeks. So that is an actual target. Most of our patients go through that pathway, but obviously there are delays when we are unable to meet those targets because of there is a clear crisis in the radiology aspect at the moment.
Yes, so it takes approximately 4 weeks, 2 and 2 weeks, 2 from screening until the patient receives the results?
Yeah. No, the patient, from screening, the patient gets the results within 1 week.
Within 1 week, okay.
1
Then
week.
2 weeks to do the scheduling.
Yeah.
Yes, thank you. And Dr. Bretu?
Dr. Amruta Talwalkar, thank you very much for your detailed and analytical presentation. I would like to ask you, if we have an additional MRI lesion, is it recommended or even mandatory to perform a second look ultrasound? And if the ultrasound shows benign features, then what should we do?
So if there is a second MRI lesion, obviously the need for second look arises when we are clearly concerned that this could be a further malignancy. We do discuss all of this in our multidisciplinary team meeting, and it is mainly to assess whether a further biopsy would change the outcome for the surgical or oncological outcome for the patient. And in most cases, our oncologists will ask for a second biopsy just in case the biological features of the tumor are different. And we have had cases where there is multifocal tumors with different biologies next to each other, which then affect the oncologic management.
Yes,
We need to
indeed.
end up biopsying most multifocal tumors, yeah.
Indeed, because biopsies should be performed just to avoid overtreatment. Thank you very, very much.
We thank you. Looking forward to seeing you in Athens next time, physically. Thank you.
It was an honor. Thank you.
Thank you.
Θα ακολουθήσει το επόμενο Προεδρείο, ο κύριος Μεταξάς και ο κύριος Παπαδόπουλος.